very much for the opportunity to be here. It's always lovely to be in Paris in spring and to be able to share some of this really exciting and interesting different views of what may end up being the same data. And I just want to take a little bit of a moment to say the last time I was in France doing a debate, I was debating BART. And we had a very heated exchange. I think I won that one. And now I'm debating one of Bart's trainees, and so on a topic where he's using a bulk of my papers to support his evidence. So thank you, Professor Moti, for putting me in that very interesting position. So what I'm going to talk about is that second-generation proteasome inhibitors are the optimal approach for patients with early relapse. And so there are a couple of things that I want to do to set the record straight. You've heard from our mountain-conquering colleague earlier on about his spin on what's best in any given situation. But I think it's important that we be objective about what's best. And when I say, how do you measure what's best? It is overall survival is the endpoint that probably defines what's best. And so, again, to quote Bart, long-term outcomes are really what matter. So if you've got a trial with a median follow-up of 2 or 3 years, that's probably not long enough to claim that this is the best treatment. And so what I'm going to use is trials that have longer follow-up than 3 years and trials that show overall survival benefit to really drive the discussion that I think second-generation proteasome inhibitors are, in fact, the way to go in early relapse. I'm also going to talk a little bit about what's unique about proteasome inhibitors and then talk about what's the best partner for a monoclonal antibody. And I think that as we get to the end of that, that will then relegate monoclonal antibodies to third-line therapy after you've used a proteasome inhibitor earlier on. So I think it's important to realize that while we talk about cancer biology when we talk about myeloma, and this is a Circos plot of the many genetic abnormalities in MM.1S, a myeloma cell line, at the same time, the single most important feature of a malignant plasma cell is this, which you don't need high tech to be able to see. This is endoplasmic reticulum that's making lots and lots of monoclonal antibody. So as we learned for decades before I actually came on the scene in myeloma, you can combine lots and lots of ineffective alkylator agents, i.e. perhaps you might want to think about that as a total therapy approach. And you don't really advance the care as you have with the addition of proteasome inhibitors, IMiDs, and other classes of drugs, because those drugs don't target basic plasma cell biology. And so if you really want to think about ways to attack myeloma, you think about what Larry Boyes from our group calls the tau of myeloma. And that is there are 2 halves to every plasma cell. There's the cancer biology side to every plasma cell, and then there's the plasma cell biology side to every cell. And this is really important because these two are very different, and we use different drugs to try and attack them. And here's an example of the drugs that one might think about, and what I want you to notice is that other than melphalan and Doxil, nothing on the right side of the tau actually is FDA approved or has significant single-agent activity. All the drugs that are really effective are on the left side, and that does include monoclonal antibodies, but a linchpin to changing the survival of patients with myeloma has been the use early and late of proteasome inhibitors because they are so central to plasma cell survival that when you dysregulate proteasome function, it has probably one of the largest impacts on survival. And to really highlight that, I want you to see this series of subsequent survival from the Mayo Clinic and Shaji Kumar's data suggesting that the real move forward on the survival curve occurred after the approval of bortezomib and during the early trials and around the time of approval of carfilzomib. That's what really moved the survival curve to the right. I don't see monoclonal antibodies on the scene that have done this to what we're talking about. And again, when you're defining best, overall survival needs to be the benchmark you use to say, mine is better than yours. So what do we know about data on second-generation proteasome inhibitors? Well, you saw a little bit on this from Saad earlier on. This is the tourmaline trial, IRD versus RD. And again, there was a difference in PFS, but to me, this is actually a very interesting different argument. And that is, if you look at patients with high-risk disease, as was pointed out earlier, this is clearly an unmet medical need. These are a group of patients whose outcomes in general are quite poor. And I'm showing you a PI-based approach that says we may be able to normalize their outcomes in terms of progression-free survival. Now, this is not a long-term outcome, so Saad can attack me for using the same short-term data that I'm attacking him for. However, this is such an unmet medical need group that I think that this is worth pulling out and at least adding up there for your consideration when you decide who the winner is. Now, let's talk about carfilzomib. There are two big trials with carfilzomib as part of the treatment approach in terms of relapsed myeloma. The first was the ASPIRE trial, KRD versus RD. And again, you'll see big difference in progression-free survival favoring the triplet, not a big surprise, and a difference in overall survival. Did you notice in the last presentation, with all the data sets that we're talking about, PFS with combining with len, PFS combining with bortezomib, no overall survival data was shown. There is a difference in overall survival from the ASPIRE curve. Again, long-term follow-up tells you what's best, and overall survival is a metric by way to look at that. Now, if you look again here, there's another important piece of information that you can see, and it's actually here. And that is, if you begin to look at overall survival, one of the key features that gives you the longest overall survival was treatment in the context of first relapse. So if you wait to second, third, or fourth relapse, you're losing that overall survival benefit that we saw from the ASPIRE trial. So if there's a rationale to try and prolong overall survival, remember, the gold standard of long-term outcomes, you need to use a second-generation proteasome inhibitor early in the course of relapse. Now, what about other potential approaches to using carfilzomib? Well, this is the ENDEAVOR trial. Again, you guys have seen this data. There's nothing unique or new in the schema. You all know this trial, KD versus VD. Again, this was the difference in response rate between the two arms. Response is a short-term endpoint. This is PFS, big difference in PFS. PFS is a short-term endpoint. Overall survival. I'm showing you two trials now with carfilzomib showing us overall survival benefit in the context of early relapse. What's the best way to measure your choices? Overall survival is the best way to do it. Now, here's a little observation that people don't often talk about from the POLLUX trial, and that is if you look at DRD in terms of response rates, first relapse, which is on the left, versus DRD in second or subsequent relapses, which is on the right, there's no difference. Overall survival or overall response rate, all the short-term endpoints are actually the same. So if your goal is to say, I'm going to give the treatment with the best overall survival first, which would be carfilzomib-based therapy, you're not losing anything when you move daratumumab to second-line therapy because the response rates are the same. It's almost identical. And in fact, if you take that one step further, these are the whisker plots looking at PFS in the DRD versus RD arm. And again, first versus second or third, it looks identical. So save it for second or third because the outcomes are going to be the same. But the survival with carfilzomib early is better. So that's why it gives you the potential way to think about sequencing therapy. Now, when we put all of these trials together in amalgamation, look at the box on the right. How many have a survival difference on the right? 2. What are those 2? Carfilzomib in both. So again, the best long-term outcomes, overall survival, best survival is linked on the right. Now, I'm going to tell you, I'm going to finish up with the idea that the best way to really think about partnering monoclonal antibodies is probably an IMiD. That's probably the better partner, simply from a biology-based perspective. And this is data from a JNUCA that he presented in our situation where patients were beyond first relapse and they received DARA in combination with pomalidomide. So if you've used REV up front with carfilzomib, like the ASPIRE trial, then you're saying to me, well, what's the partner for DARA? Well, the partner is pomalidomide. Pom-Dara is probably more potent and more effective than Dara-Len, at least when you look at response rates. And there are randomized trials now looking at Pom-Dara-Dex versus Pom-Dex. So we'll see that. But I would argue that the best partner for the antibodies is actually pomalidomide. It may not be lenalidomide in terms of how you do that. And in fact, if you look at progression-free survival, it's quite long. If you look at median PFS, this middle bullet here, for cohort 1, which was the patients that were Pom and Dara naive, median PFS has not been reached with a median follow-up of 17 months. So this can be potentially just as good as the data we've seen for Len-Dara-Dex, but you use it after you've used carfilzomib in first salvage. So what are the take-home messages? Well, the use of PIs, and in particular from this data set, carfilzomib, are central to improved outcomes in myeloma. Current follow-up of clinical trials say, I'm not suggesting, I'm saying it, that overall survival is improved with the use of carfilzomib. Benefit in monoclonal antibodies is the same, whether you use it in first or subsequent relapse, so why would you rush it if you've got another drug that does in fact improve survival? And the best partners for antibodies, again, are probably pomalidomide, so wait until second or subsequent relapse to use Pom in combination with your favorite monoclonal antibody. So I'm going to wrap up telling you that tomorrow is a big day in the United States. So I'm from a little city called Louisville, which is in Kentucky. And they have a famous horse race that's been run for 144 years. And that's called the Kentucky Derby. And you can see it's important here. And coming into this debate, it was pretty clear to me that Saad was the favorite. He had the one that everybody wants to talk about. He had the Dara and the ELO and the antibodies that everybody wants to talk about. He was using most of my papers to support his evidence. And so he had the inherent advantage of trying to win this debate. But it turns out that in 143 years, less than a third of favorites in a horse race actually win the horse race. So I'm telling you, as the non-favorite coming from behind, I think I got a good shot. And this is actually what Churchill Downs looks like. It'll look like tomorrow. Beautiful sunny day. And what I'm telling you is, you don't want to be the horse in the back. You want to be the horse in the front that's winning the horse race. So vote for the right, pick the right horse, and do well. Thank you.